Good morning, everyone, and thank you for joining us for our first presentation of Mapping Your End-of-Life Journey. My collaborator this morning is Rachael Paje, palliative nurse clinician with Fraser Health, and Rachael works in the White Rock, South Surrey area, serving families and patients. As we get started, I would like to take time to acknowledge that we are being hosted this morning on Coast Salish Nations traditional and unceded territories, and that those nations are Kwantlen, Katzie, Tsawwassen, Semiahmoo, Stolo, and Saanich nations. And as we stand alongside the Truth and Reconciliation Accord, it really behooves each of us to acknowledge our histories with these lands and our access to the resources connected to these beautiful lands. Thank you so much. So welcome again, Rachael, and I would like to start our conversation by finding out more of how you came to choose your professional role as palliative nurse clinician. What brought you to this role?
Hi, nice to be here. Thank you for inviting me. It's obviously a topic and a subject that I'm really passionate about and have been for a long time. The journey started way back when, in a couple of lifetimes ago probably, but I didn't do my nursing until I turned 40 and I got my RN with the purpose to become a palliative nurse. I'd had a few experiences in my life. I'd been involved with people and places in my life that kind of made me think this is what I did want to do. But then after my family and myself cared for my dad at home palliatively for 4 months, we all moved in and took care of him as he passed from cancer back in 1999, and that was kind of the last piece that I needed to prove that this is where I needed to be. So after doing that, I did my nursing degree in England, and I moved here with my family in 2008, and we've been here ever since, and I've been working as a bedside nurse in an acute oncology, hematology unit. Then I went to the tertiary unit, which is the palliative complex unit in Surrey, and then moved into the clinician. So I've been doing this now for about 15 years altogether, and I'm just every day humbled. Every day I meet such amazing people, and to be able to support people at this time in their life is a really, it's an absolute honour to be able to do it. So it's something that I'm very passionate about, and this subject as well, especially end of life at home, is something that's very close to my heart and something that I really feel that we need to get it right. It's a bit like a good birth. You always love the baby, whatever happens, but if you've had a really bad experience having a birth, you can never kind of just let go of that and forget it.
Yeah.
I think it's similar at the other end of life, that we just really need to get it right, help and support the families, and we need to do what we can to keep the loved ones as comfortable as they can be at the end. So it's a very important role, and I'm glad that it's something that we can maybe help support and just educate people about as we go forward.
Excellent. Well, I know that you are really the right person in your role, and your personal experiences add to your professional credentials, right?
For sure, you kind of lived it. You know what you're talking about. You've been there. You know how it's going to go, and that's the experience that sometimes families don't know, and they're not sure what's going to happen.
Yeah. So Rachael, research shows that 70% of people questioned would like an end-of-life death at home, yet only 15% actually receive that. Can you speak to why such a short percentage of people actually have that at-home end-of-life experience?
Yeah, it's one of those things we talk about. We try and get patients and families involved in these conversations as we know that what the trajectory is looking like, as we know things are going to change quite quickly, and we do know that the end is within sight, and we start having these conversations, what's important to you? Where would you like to be? How can we support you and your family? And there are so many variables that come into this, that to say, and 99.9% of the patients will say, I just want to stay at home.
Mm.
What that involves and how many people that involves, that's the piece that's the unknown. So people don't know what they don't know. So we can help and support. But if you've got a 90-year-old patient and his similar aged spouse, and they're the only two in the home, being able to support somebody at home to the end is not feasible unless they've got a lot of money, or they've got a lot of supports that are willing to come in and spend a lot of hours helping to support that. So there's so many variables that play into this, that I think it's always the best intention, and it's always the way that we try and support the patients at home. But often it's just too much to manage. It ends up not being the right place for many.
Yeah, and going back to the birth parallel, it's just like in birth, you can plan for a home birth, but hospital is always, or the birthing center is always the backup. Yeah. So can you tell us a little bit about the how the palliative care plan, if somebody is recently enlisted on the palliative care plan, what's the best way for their family members and themselves to initiate that communication with home health, or how does the whole process begin and evolve?
So we in BC, and especially in our area, it changes drastically in different areas, but here we are so fortunate that we have such an amazing system and a support system, and we've got really good doctors, we've got lots of community support. So I think we have an amazing system here. We have an initial, it's called Home Health Service Line. It's just one initial number. As patients are referred to, they can refer themselves, the family can refer, the GPs can refer, family members can refer, the cancer agency, they'll often refer. Doesn't matter where the referral comes from, it comes to a central point. That central point will then triage the call and pass it to the right office. So if, say, a family member in White Rock is wondering how they're going to best support their mum or dad, and they're not really sure what supports they need, they've been told by the doctor or the oncologist that they've maybe got 6 to 12 months to live, and they want to start this plan, they want to start getting things in place. Home Health Service Line is the place that will be contacted. That referral will come to the home health office here in White Rock, and they will then make up a chart, and they will get in touch with the family and say, okay, we've received this referral, we need to come out and admit you to the palliative program.
Okay.
So it's like a one central number, which I can give you at the end, and you can put that on your resources.
Okay, super. Thank you.
Access that if you need to.
Okay.
And that way it gets sent to the right place, to the right people, and then they will contact the family. So that's how it all starts.
Okay. Okay.
Yeah.
And then so the kind of requirements to be hospice eligible, can you speak to what the eligibility for hospice is, and long-term care, what that would look like?
So once you're on there's just a couple of different distinctions. There's the palliative program, which is within Fraser Health, is our program, which is saying that you're over 19, we know you've got a life-limiting illness that has no cure, and that you are probably got a life expectancy of 6 to 12 months. Okay. That's eligible for the palliative program. There is a palliative benefits program, which is different. That's a BC federal program. So there is a couple of distinctions with that. But you're on the palliative program, and then you want to stay at home, or there's the option of hospice, or there's the option of residential care. There are it's a different criteria for each. It's a different process to get into hospice than it is to get into residential care. The big difference is they both provide 24-hour care. They both have doctors and they have nurses that oversee the care of the patients in the facilities. But with hospice, we're usually looking at the last few weeks to short months of life. So we're trying to prognosticate that this is definitely the end. Whereas with residential care, the average stay in residential care at the moment here in White Rock is probably 12 months.
Okay.
So it's when they've got a little bit more of a longer trajectory but need 24-hour care. And the other difference is that in residential care, you'll often find that there are social events going on. They'll go down to a dining room for communal meals. There's a lot more participation. There's a lot more socializing. Whereas in hospice, it's pretty boring. You know, there's not a lot going on, you know. Mainly it's patients in their own rooms, bedbound, not able to get up. Families are coming in to visit in the rooms. So, you know, it's not usually where you would go if you've got a longer trajectory, because it's not the right place to be.
Right.
And going into residential care with a longer trajectory, they will provide end-of-life care. So you wouldn't stay in residential care until you became too ill. They will keep you there till the end. So it's a bit like an extended hospice is residential. But you'd stay for a longer period of time. And like I say, there's differences with the funding and how you pay for it. There's funded beds and there's private, which is a completely different field to what we're in. We would just say whether somebody's hospice appropriate or not, and then it goes over to another team. But that's the big difference between the two.
That helps. That's really clear. Thank you. Okay, so let's shift our conversation then to if somebody is on the palliative care plan and the palliative benefits plan, and say my partner has been diagnosed with a life-limiting illness, and he has been, the doctors prognosticated 1 year. He has 1 year to live. What could we expect from the home health nurses in that situation?
So we've received the referral from Home Health Service Line. The GP's put it forward to say that he wants these patients to be registered and to be cared for and monitored in the community. The home care nurses will go in, they'll open up, when I say open a chart, they'll have a big folder that they'll go into the home, they'll connect with the patient and family, spouse, whoever's involved in the care. They're going to be able to give lots of resources. They're going to give you lots of information. They're going to give you contact numbers. They're going to give you local resources for the area. They're also going to be a link between yourself and the GP. So the home care nurses are going to come in. They're going to support pain, symptoms. They're going to be able to support mobility with equipment that might be needed. If there's adaptations that need to be made in the home, they can ask the community to come in. They can do all kinds of simple things like grab bars and toilet seats, commodes, walkers, lots of things that they can help to keep patients at home longer safely. And if things are changing, they can add in more things. So there's going to be OTs that can come in. The home care
What's an
nurse,
OT? Sorry.
occupational therapists. They're the ones who arrange the equipment. They can do assessments of the living space. You know, if we could just change this round, or we could add this here, and just something as simple as a sidebar going on the bed, so that they can help get themselves out in the morning. Little things that you might not think about or know about. That, you know, these are the professionals that are going to be able to come in and help support that. So the equipment, the home care nurses are supporting the physical and the mental. And we have a social worker that's attached to our team. So, you know, families are saying, well, I want to stay at home and look after my loved one, but I've got to work, I've got financial issues. So this is where the social work can help. They can help with compassionate care benefit, which is a short-term benefit where you're paid to stay at home and look after your loved ones. And this is the sort of thing that the social worker can help with. And this is the home care nurses do this every day, so they know who to access and when.
Right.
So as you're telling your story and you're telling us how things are and what your struggles are, we are hopefully going to be able to help with the right people coming in.
Right.
They may come once a week to start with. They may just call once a week and then make a telephone call. They might, it just depends what you're needing.
Uh-huh.
It'll be a negotiation. We'll talk about, at the beginning as well, we will talk about getting our paperwork in
Uh-huh.
because there's certain paperwork that we need to have in place, like a do not resuscitate order,
Uh-huh.
palliative benefits program applying.
Mm-hmm.
And there's more documentation as we go on
Right.
to need to have in place, which all makes things easier as we go down the trajectory,
Right.
as we change.
Right. So you're really
Conversation-
looking ahead. It sounds like your team can see what's happening up ahead, and I can really see how a family, doesn't necessarily want to look ahead.
And it's
So it's very
hard work.
essential.
It's very sensitive.
Yes.
Talking about things that, like you say, some families, it's not that they don't want to talk about it, but either they don't know how to approach it and they don't know what they need in the first place. And sometimes there's this misconcept that if we don't talk about it, it might not happen.
Right.
And that's the hard one as well. It's not denial per se, but it's like, if I don't talk about it to my loved one, they won't get hurt. And if they don't talk about it, they won't get hurt.
Yeah.
But at the end of the day, it's the elephant in the room, and we all know what's happening. And the more prepared we are for it, the more open it is. In my experience, often the easier it goes, and the better everybody feels throughout this journey.
So, yeah, I'm sure the team is very, very skilled at maneuvering those conversations
And that's hopefully, and this is why I was getting in early. We help to build up this relationship. You get to know the home care nurses, a smallish team, about nurses, and you get to build up a rapport with them. You get to know them. They come in more frequently as things change, and you know each other by name. Then it just makes it easier the sooner we get in. If there's a crisis a few days before someone dies, it never goes that smoothly. We do what we can do, but we're trying to avoid hospital. We're trying to avoid hospice if we can, but so the sooner we get in, the sooner we can plan, the sooner we can get things in place.
Yeah. Okay. So let's turn our attention towards the care provider. So for myself, if my partner still had 1 year expectancy to live, what can I expect? How should I start preparing myself, for example, work-wise, and how long do I need to be at home? Should I start enlisting other family members at the beginning of that first year?
Again, it's all about the communication, knowing what supports are available within the patient's own family and work. So, how many people are going to be involved, having these conversations, who is prepared to help out when things to the point that they're needing more care. With a year's prognosis, I wouldn't think that people needed to be that involved at this point, because we're still going to be able to manage to care for ourselves. We're still going to be eating and drinking. We're still going to be pretty mobile, although resting a lot in between. But I think we'd be pretty independent with the trajectory. But bring it forward 6 months, and that's when, these pre-conversations that we've been having are, okay, I can't leave my loved one alone. They're not safe to get up on their own. They need help to get to the chair, to the bathroom. We've got equipment to help with walking. We don't feel that they're safe to be left anymore. So we need round-the-clock care, basically. So the home care nurses will recommend some home support that come in, and that's home support is available to help with personal care. They can come in the morning and help with a shower and to get dressed. They can come in at lunchtime and help them to get to the bathroom, to prepare a little bit of lunch, a sandwich or something. They can come back at night and they can help get them to bed.
So can they come 3 times a day? Is that what you're saying? Or they can choose one time to come?
They can come for a maximum, as the patient becomes less dependent, the maximum that the home support can be provided is 4 hours per day.
Mm-hmm.
Those 4 hours have to be attached to activities of daily living. So they have to be coming in to do something. They can't just come for a 4-hour block and sit and not babysit, but sit and just make sure that they're okay.
Right.
They have to come in to do tasks. So
could they come 3 times in one day, and that would total 4 hours?
Yeah, they come 3 times, they can come 4 times, they can come whatever, however.
I see.
However, like in the morning, usually the bed bath and the changing, and if there are any wounds that need dealing with, that could take longer.
Yeah.
And maybe just a quick stop to another couple of times during the day. So it's up to 4 hours, but that still leaves 20 hours when the family are responsible for the care of the patient. Mm-hmm. I always say right from the get-go, it takes 3 people or 7 to basically care for somebody at home till the end. It's physically and mentally, emotionally draining. And this is the piece that I can sometimes, that patients and families like, 3 people, all he's doing is staying in bed and sleeping. They're not really doing anything. But it's the emotional impact of losing your loved one, on top of being sleep deprived, on top of not sure what medications to give when, on top of, well, they're not eating and drinking, and what am I doing right, what am I doing wrong? It's all the pieces that you don't know what you don't know. That piece, I can't overemphasize, takes the biggest toll. You know, I've done it for patients and I've done it for loved ones, and doing it for your loved ones with the emotional element on top makes a huge difference. So, you know, talking to your family, working out a schedule, who's better up in the night, who's better up in the day, how can we spell each other off so that we're all getting our rest, and really we try and look at the whole family. We look at the whole picture. Right. We've got this wonderful story or visual that I use all the time of we as the home care nurses are watching the patient who's in the middle of a dance floor. And around the dance floor are all his family and friends, and they're all doing their dance, trying to keep this patient as well as they can and as comfortable as they can. And we as the home care providers, as the nurses on the outside of the dance floor, are watching all the participants on the dance floor. And it's our job to just make sure these pieces move simultaneously and as well as can be expected without getting on the dance floor. So if a home care nurse comes in and says, you know, I recommend that you just say yes. It doesn't matter what they're recommending. Just say yes. You'll think, I don't really think I need that, but anyway, they are on the outside of the dance floor. And sometimes when you're so submerged in it and you're day in, day out, fully concentrating on this patient, not perhaps eating as well as you should be and sleeping as much as you should be, it's good to have other people kind of, we've got your back, we're just going to help you with this and make sure that you're getting the support you can get and what you need. Yeah. I
love that analogy of the family dance floor. Yes, we use it. We use it with volunteers as well. Stay off the family dance floor. Yeah. Okay.
I think that sort of covers, you know, what we would do and how we can best support patients at home as things start to change.
Right. Right. Yeah. So that's a good segue to the more active dying phases, or when symptom management takes up most of the focus. Maybe you could talk a little bit about, you know, what we could expect in those 3 to 6 month range of changes in the physical and cognitive and emotional for the person who is dying.
Yeah, so we're definitely going to see that they're going to be sleeping more, resting more, and not engaging as much. You know, you think, well, just sit and we'll chat. even sitting and chatting becomes exhausting. So short periods of conversation, you know, if visitors want to come in, you know, he's really popular, he's got lots of friends that want to come and basically say goodbye, but want to come and personally see. You sometimes have to be the visitor police and say, you know, but for 10 minutes only. It's amazing how quickly people fatigue at this time. Not engaging as much, sleeping more, not wanting to eat and drink as much, and not wanting to eat and drink at all. At the end. And as family and as we socially, we are geared to feed, to nurture. You know, that's how we show our love, and that's how we care for people, is by feeding them. So it's very hard for us sometimes to accept that they no longer need food, they no longer need drink, because their bodies are not able to tolerate it. This closing down process. As they are sleeping more, they aren't going to be eating, but they're not going to be feeling hungry either. So it's, you know, it's not to feel that they've just laid there starving to death. They're not. The bodies are naturally shutting down, and with that, the brain is told that it's not hungry, and they don't feel the hunger. So we will be showing you how to do good mouth care, keeping the mouth moist, keeping the lips moist, so they're not feeling the dryness of the mouth, which could potentially cause them some distress.
Right.
So sleeping more, eating less, engaging less. Those are kind of the things you're going to see day to day that will just carry on.
Right. So, and then I would expect as well that the home health nurses would be preparing us, myself and my family, for, you know, what to expect as time goes on, and perhaps helping us with medication, reassessing goals of care, that kind of thing.
And that's, you know, these are the things where it's really important. By this time now, the home care nurses might be coming in 2 or 3 times a week. As it gets nearer the end, they'll be coming in daily. But say we're just a little bit out from that, 2 or 3 times a week. If we're no longer able to swallow medications, but we're still needing medications for pain, shortness of breath, agitation, restlessness, all these things that we may see at the end of life and commonly do. By now, we've stopped all non-essential medications. Anything that we can't swallow that we don't need, like our blood pressure pills and our statins, we don't need them. We're going to stop as much as we can. So we're going to, medications that can't be swallowed that we still need, we're going to put a little subcutaneous butterfly, which just goes in usually at the top of the arm. The home care nurse will insert that. It's not a needle, so that the needle comes out after it's administered. And then the medications will be drawn up into little syringes, and we'll draw them up and leave them in little containers. And educate the family how to give it. It's a needle, like I say, it's just a twist on, administer the medication and twist off. So we'd show you how to do that. We're going to monitor the site. We're going to educate you into when the medications are to be given, how often. There's a sheet in one of the charts that we give you that you can document it so you know when to have it and how often. So all that's taught, and you're educated around that. So the medications as well, the family doctor will be involved for as long as possible, but if it gets to the point that the patient's symptoms are really not managed and they could do with a doctor's visit, we have a palliative physician that will come into the home. And he'll come into the home, he'll reassess the medications, he'll do new prescriptions, he'll support the family, he'll support the home care nurses. So that's another link. The doctors to each other, the family doctor can speak to the palliative doctor and ask him to come in and do an assessment and to help out. So there's a kind of a link all the way around. Myself, I go in with the home care nurses as things are changing to help support the family. The doctor can go in, the social worker can go in, all along with the family in the middle, and the home care nurses supporting around that. So there's lots of support, but again, it depends how many people there are involved, what the dynamics are of the family. You know, if, let's be honest, not all families get on. So the fact that they have to move in together or they have to be together for long periods of time amidst the emotional upset and turmoil that's going on with a loved one, sometimes it's just not doable, you know, and acknowledging that and saying, well, I can't be with you in this room for more than 10 minutes, so this is not work, you know. We have to, dynamics of families don't change for the better usually in my experience because of something like this, you know. The dynamics are there regardless, and we can either work with them or we can decide, you know what, it's not going to work, we have to look for a plan B.
Right.
But we have to kind of consider that as well.
For sure. Yeah. So you just answered my next question. Thank you. Like, how do we assess whether our family has the wherewithal to go through a home death? But maybe you could talk a little bit about the positives. Like, why would a family want to do this, and what are the benefits of going through this experience?
And those are the massive, you know, the benefits, and when it does work well, it is very rewarding for both the family and the patient. So the big thing at the moment is that you can have as many people in the home, around the patient, all the friends and family, you can all be together.
Right.
Amidst the COVID, you know, we have major restrictions in the hospital and in the hospice, which I'll speak to in a moment, but the visiting restrictions that we have to impose are not imposed in the home. So you've been able to all be together, supporting each other, your loved ones where they want to be in their own surroundings. That's the huge, it's huge for everybody.
Right.
And able to support you from the home support workers, the carers that can come in, and the nurses coming in. Hopefully you feel well supported in that you're getting the help that you need. So usually the benefits do outweigh the burdens. But it is hard work and it is relentless, and we're quite good at prognosticating when somebody's got a cancer diagnosis. A little bit more difficult when it's a non-cancer.
I see.
So, you know, when we're talking about a cancer, we usually see the trajectory, and it does generally do this, and we can tell you pretty accurately what kind of time frame we're talking about, depending on the type of cancer and where it is. Somebody that's maybe got a congestive heart failure or renal disease or an end-stage dementia, there's a lot of dipping and diving. So we might drop and think, okay, this is it, and they just perk up a little bit, and then okay, we're going okay, and then it happens again. At one point, that will be the last dip. But when it is kind of harder for us to prognosticate. So if we've taken time off work, the family's all rallying around because we think we've got probably a couple of months that we're looking at, and that 2 months turns into 3 months, then turns into 4 months. And that can be another issue that we have to then look for a plan B. Right. We have to get back to our different lives, and we have to get back to normality. So
So it sounds like, you know, planning an at-home death involves a lot of preparation, and that includes hospice as a backup. Is that what you said?
That's what we like to propose that. It's not a big ordeal. It's not a lot of paperwork. It is maybe half an hour's worth of paperwork that we'd need to do in advance. Knowing that if there was a crisis, if there was a point where we said, okay, we can't manage this any longer, we don't have to have hospital as a backup. We don't be going back to emerge and going through the trauma of being, at this point, would be an emerge on their own because there's no visitors allowed.
Right.
So going into an emergency department on our own in some kind of a crisis, I feel would be the worst case scenario. But coming into hospice, we've got the paperwork, we know there's a bed at this particular hospice. It's usually only a matter of days before we can get an admission to hospice. But usually coming into hospice is the second best choice. It's more of a homely environment. You've got a private room. You can have 2 visitors a day at the moment. So people can come and be with a loved one. It's a nice environment. It's calm. It's peaceful. It's not like a busy emerge. So having hospice as a backup, and being able to think that, and it's good for the family to know that, you know, if they can't manage, that we do have another plan in place. It gives them that reassurance that it's not the end of the world. If we can't do it, we know where we're going and how it's going to look and what's going to happen.
I'm sure that's very reassuring.
Yeah.
So if a family is planning to have an expected home death,
Yeah.
What kind of pieces or paperwork do they need to do prior? And yeah, let's start with that question. What kind of pieces and paperwork do they need?
So hopefully by now we've got a DNR in the home.
Okay.
You'll be given a green sleeve, which is a plastic little wallet that's got a magnet on the back, and that sits on the fridge. The BC ambulance men know where to look when they come in if they're called, and they'll be looking for the green sleeve on the fridge, which have these important documents in, like the DNR, the palliative benefits. And there's another.
Can we just back up a bit? Sorry, Rachel. But if when the person dies, the ambulance is not coming to the home.
No, I'm getting to that now.
Oh, sorry.
But this is in case prior to this.
Okay.
Anybody who's got a DNR, that's where it should live, on the fridge.
Okay.
I had one old lady, she said, I like that, the idea of them knowing, but it's in the fridge because I don't like it on the door. So she kept it in a freezer.
And were the paramedics able to find it?
I don't know, she didn't need to call them, but I just thought it was funny that she's okay with the fridge, but she wants it in the freezer. Sorry, I digress. So there's another form, it's called an expected death in the home form. We call it ED. We call it, it's not a very nice named form, but this form has 3 parts to it. The top part has the funeral home that the family decided they're going to use. The middle part is completed by the physician saying that, yes, I do expect that this patient will naturally die from their disease. The bottom bit is to be signed and documented by the person who is responsible for calling the funeral home, which is usually the executor of the will, the next. So it's a 3-part form. It's a triplicate form as well. There's 3 sheets to it. One sheet stays with the patient at home. One sheet will go to the funeral home, and one sheet will go to the home care nurses, and they'll keep it in the chart. This form's good for 3 months, and then it expires. What that means is that if your loved one does pass away at home, middle of the night, you wait for an hour after you think they've passed, and then you call the funeral home. So they don't need to be pronounced, you don't need to call an ambulance, you don't need to call the doctor's surgery, you don't need to call anybody. When you're ready, at least an hour after, but you can wait for as long as you want. If you need a relative to come from out of town and they need their goodbyes. Once somebody's passed, they've passed.
Right.
Time is yours. This is a time when you can be together. You can have time to say prayers, to do any rituals you want to do. It just should be a peaceful time where you can grieve together. So it's a really useful form. Stop there being a crisis if it happens, to stop it being something that's really you know, you're not running around, okay, now what do we do? We're in an emotional state, don't know what to do. So this form is something that we will be recommending that you've got in the home as we think it's getting nearer to the time. So it's, again, another planning, but once it's done, keep it out of the way. It's not right. Hesitate. It just helps us then if something does happen, it means that you've got a plan and you know what to do.
Right.
You can still wait for the home care nurse to come and pronounce. It doesn't mean you can't, but they can't come in the middle of the night. They can't come when it's inconvenient. So it's usually like 9 to 5 when they can come and pronounce, which is fine if you still want that. But if you don't, or it's the middle of the night, at least you've got this form in place and you can just decide yourselves when's the right time to call the funeral.
Do you need to record or call in the time of death? Is that important?
It's important to know that the home care nurses will be by this point, they'll be seeing you daily anyway, so you can call them in the morning. They usually call every morning before they come out to do a home visit, just to check what time they're coming out. So yeah, when they do call or when you do speak to them next, just let them know that your loved one passed and at what time.
I see. Now, what are your recommendations around, say, children at home, if a loved one is dying and there's children at home?
Yeah, there could be young children around. There could be the patient's child, or they could be grandchildren of the patient.
Right.
You know, we suggest normalizing this as much as possible. It is part of life. Pretending it's not happening, lying to them, really unhelpful. So letting them see their loved one, be able to snuggle upon the bed with them, answering the questions that they're asking at an age appropriate, with age appropriate answers, kind of identifying who might be the best person to answer those questions. I think the children usually tend to go and ask the person that they feel comfortable asking, right? They usually lead this. The schools usually have good counselling support. Hopefully the school's been informed that this is happening. I know through the Hospice Society, you've got an amazing support through the counselling service as well, that family and children can access. And that's obviously something that's been talked on at length in other slides and other views. But yeah, so school counsellors, if they're attached to a church, there's often people at church that can help. Family, just answering the questions. There are lots of books around as well that we could access to help children, depending on their age and everything, and where they're at. Keeping it as normalised as it can be. The emotional piece is always something that we have to kind of talk through with them, seeing their loved ones crying and not understanding why. So the emotional piece, just trying to explain it at their level.
Right. Yeah. That sounds reassuring. Now, we've talked a little bit about, not wanting to take our person to emergency if there's a crisis, and we have the expected home death form and hospice as a backup. But what happens if my partner is in crisis and I really don't know what to do? What can I do in that situation? And it's the middle of the night.
Middle of the night. So yes, you always do have ER as a backup. You can always dial 911. And sometimes that is actually appropriate.
All right.
The symptoms. Some other cases that I've seen where they have had to go in, as if if a tumour erupts and it starts to bleed out very quickly, that can be very traumatic, and they can't manage it at home. And sometimes the pain, we're feeling that the pain is, or the symptoms are just can't get them comfortable, they just can't get managed. But it wouldn't be my first choice to dial 911. When you are admitted to the program, you'll be given an after hours number, and this number can be called from 9 p.m. to 8 a.m. And clinicians like myself, we're on call overnight. We triage telephone calls, and often we can really help support at this time with helping with the medication piece, with the symptoms, trying different things. So sometimes calling the after hours number is a really good starting point, and sometimes we might have to recommend that you do dial 911, but often that's somebody to talk to. It's somebody that can talk you through what's happening, and often it's the reassurance that you need. It's often I think they might be dying and I'm not sure, I just need to talk this through with somebody. Sometimes I just sit and chat with people at night because they just don't want to be on their own. It's just but yeah, if it's a proper crisis, call the after hours number first. We'll triage the telephone call, we'll support you as we can over the phone, and if we feel that there's nothing we can do, then we'll have to say dial 911.
Mm-hmm.
but to have the after hours to start with.
Mm-hmm.
The home care nurses can be called as well through the day, and they're available up to 9 p.m. as well.
Mm-hmm. Mm-hmm. I just want to touch on a couple of pieces around caregiver burnout from your perspective. You know, we do have Rick Dilworth talking specifically about caregiver burnout, but from your perspective, how you see that and say strategies to avoid that, and then something that families can perhaps diagnose on their own or misunderstand, and that might be over medication or not receiving enough medication, those from that perspective.
So caregiver burnout is very real. It's very disabling and debilitating at times, especially for a long and extended length of time. Like I've said, sometimes we're all focusing on the patient and then neglect ourselves through doing that. So it's really important to make sure you eat regularly, get as much rest as you can. If you're the main caregiver, when patients sleeping, you sleep. Nap when you can, if they're sleeping, if they're napping. So really being conscious of that. If somebody's, you've got a good schedule going and somebody's coming to relieve you, get some fresh air. Try and leave their home. Really be cognizant of what brings you joy as well, and things that you do to preserve your energy and to preserve your mental health. Some people meditate, some people need to go and have a yoga class. Whatever it is you need to do, don't give up everything for the loved one. It's important. The longer you keep healthy, the longer you can look after each other. With regards to the medications that you're given are prescribed, and you'll be giving them within the time framework of what is allowed. So usually, say for pain medication, for example, there'll be a regular dose every 4 hours, but then in between, if the pain's not managed, you'd be able to give a half amount of dose, which will all be prepared for you, every hour as needed.
I see.
So you can't give too much. You're following the parameters that the home care nurse or the doctor has given you. And if you feel that your loved one is uncomfortable, is agitated, is not comfortable, isn't relaxed, then you'll have medications that you can give and the times that you can give them.
I see.
And we do find that people under-medicate because they don't want to over-sedate them, they don't want to over-medicate, but you've been given the parameters when you can give the medication, knowing that they are going to be sleeping more as the disease progresses. If you over-medicating are very slim.
I see.
But all we're doing is looking at the symptoms, and if the symptoms need medication, we give the medication. Obviously, like I say, within the parameters that we're given. But that's where the home care nurses are going to be able to help and support that. They're going to be able to reassure you with the timings. Like I say, there's a sheet that you're given where you document it, so it's very clear when you're giving and how often.
Okay.
And that's where the doctor can come in as well and adjust the medications. So follow the instructions you're given, but knowing that whatever you're giving is because there's a symptom that needs that medication.
Okay. That's really clear and reassuring. And knowing that the dying process is also taking place.
And they are going to be sleeping more. They are a lot drowsier than you've seen, and that with or without. But if they're agitated and restless, on top of that, that's distressing for the family to see. Distressing for the patient to be in that position because they might not be able to communicate what the problem is. So again, you've got a furrowed brow and they're restless and they're turning their head. To me, that would say we're either in pain, we're restless, or agitated. And I need to give that pain medication, or I may need to give the pain medication and the agitation medication together. There's combinations, and there's one's not going to harm the other one, but we might need both. And it's just a lot of it's trial and error. The big thing for families is they don't know what they don't know. being able to listen and get support from the nurses. And sometimes that's when they'll say, I don't think I can do this at home any longer. The patient can't tell me what's wrong. I'm not feeling as though I'm looking after them properly. I don't feel like the medication's working. I just want to be the loved one. I want to sit and hold the hand, and I don't want to be the carer anymore.
Right.
That should not be seen as a failure. That should be seen as we did what we could at the time, the best that we could do it. But it's now time for somebody else to take over so that we can have some quality time. I can hold the hand, tell stories, read a book.
Yeah.
And knowing what your boundaries are and knowing
Yeah.
what limits are is really important to acknowledge that,
Mm-hmm.
but not acknowledge it as a failure.
Right.
Really should not be baggage to be carried.
Mm-hmm.
And that it's just really lucky, and we're really fortunate that we have places that can manage that care and places that can give that type of care that looks after the family.
Mm-hmm. Yeah, and sometimes families know in advance what their turning points are going to be.
Yeah.
For example, if one side of the equation is not comfortable with the other person, with bathroom care, if the patient or the family caregiver is not comfortable with bathroom care, then that might be the turning point. You might know that in advance, or you might not know in advance what the turning point is going to be.
Yeah, and sometimes, often we'll have the patient will say, I just want to stay at home, and the caregiver is very unsure about whether they can manage this.
Yeah.
And they will say that while you are awake and alert, I will keep you at home. But then and once they're unable to speak anymore, or they're mainly sleeping all the time, that's when they'll say, okay, now we need to go to hospice. Or like you say, once they're completely bedbound, now we need to go to hospice. Once they're not eating and drinking any longer, now they need to go to hospice. So yeah, sometimes we do have those, we've had a conversation and we kind of know what the limits are going to be, which helps us to prepare. But the other side of this coin is we're going to keep them at home, whatever, but then for whatever reason, it just can't be done.
Right.
So it's just, it's all about the planning, it's about the communication, and it's the caregivers being really true to themselves.
Now, have you found that more families are choosing at-home deaths with COVID in place?
Yeah, more are definitely attempting it. More are definitely saying we want to do this, and they would do it for longer than maybe possible because of the visitor restrictions. It's very hard if you've got 5 children and only 2 can come in a day. You're kind of having a Russian roulette as to who can the loved one maybe before they pass. So we're even going to have a chance to say goodbye to them. So yeah, through COVID, to be honest, it has been a little bit more of a challenge. But now that we have got 2 visitors per day, that has helped. And I've noticed that more people are choosing to come to hospice a little bit easier.
Earlier perhaps, and without the crisis as a turning point.
Without it being a crisis.
Yeah. Good. Okay. So we have covered a lot of ground, Rachel, and I think that we have covered all the points that I was hoping we'd touch on. Are you feeling like we're pretty complete here?
Yeah, I think so. I think we've covered a lot.
I just want to express again, like you were saying at the beginning, how fortunate we are to have the care teams that we do at end of life. Because what you've illustrated is a very comprehensive team.
And I think that's, you don't have to go far out of our area to see that it's not just as well organized, or there aren't as many resources. But I think that's really good for families to know that there will be support with whatever it is that they need. We just, it's just kind of knowing who to access it from. So once we're involved, the team, we can help navigate a lot of things. Good for families to know.
Right, right. And so at the end of this recording, or at the end of our interview, we will have, how to get in touch with you and how to get in touch with that home health line and any other links that you feel are pertinent to end of life at home care. Yeah,
Perfect.
yeah. So thank you so much, Rachel.
Okay, you're welcome.
Okay, bye-bye,
Thank you.
everyone.